Anyway, I'll be talking about the last talk. I don't know how much time we have, but this is combining CXL with laser vision correction. You can combine cross-linking, and the cross-linking that you are doing is not the full strength cross-linking that you are doing, and you could these are called as LASIK Xtra, PRK Xtra, or Smile Xtra, and you can also combine it for surface symmetrization of keratoconus cases with doing cross linking in case there is a forme-fuste keratoconus. Now, laser vision correction alone, you know that these are the possibilities of having regression and iatrogenic ectasia, and 14 to 33% corneal weakening is there because of the flap creation that has been shown. And the thicker the flap, as you can see, that the weakening of the cornea becomes more. So typically you are weakening the cornea because of two things. One is the flap creation, and the second is the amount of tissue that you are taking out because of the ablation that you are doing. Now, tissue subtraction coupled with creation of the vertical or delamination cuts in LASIK and smile respectively, and injury to the Bowman's membrane in PRK, this leads to biomechanical instability and are known factors for the development of ectasia. It is an indeterminate value as to how many patients go into ectasia, but the incidence has fallen significantly with the outcome of the posterior float being looked at by the pentacam, etc., which is there. However, if you have high myopia, thin corneas, abnormal topography, eye rubbing pregnancy, hormonal imbalances in certain conditions, systemic conditions, these are prone to development of ectasia. You can see that cross-linking is well established, and cross-linking came in from dental treatment where the UV light was being used, and from there on the idea of cross-linking came in, and it restores the strength to the cornea. It also increases the flap bed adherence and better tensile strength is given. There have been studies to show that the refractive regression and risk of corneal ectasia are reduced when you are doing corneal cross-linking along with the laser vision correction which is there. Also, there have been studies to show that the epithelial thickness increase is less, which is also implicated in the causation of regression. Now, what are the concerns as to why Shinagawa in Japan almost does all his cases of LASIK along with cross-linking? But there could be some concerns regarding the safety, the side effects of haze and scatter, and long-term outcome of progressive flattening. This is a study by Shri Ganesha's group, where he says that if you have any of these two risk factors, so these are the risk factors, you have to look at the age, high myopia, thinnest pachymetry, residual stromal bed, biomechanical index, CBI, TBI, contributory history, family history, etc. And if he says that any of these two are, then one should go ahead. If there are no risk factors, it's fine. But if there are two of these risk factors, then and he has done a long-term study and he has found no case of ectasia, if I'm correct, in the cases of smile that he has done. Riboflavin is used as 0.25 concentration, and you don't use dextran, you use either the saline or HPMC, because that can go on to causing DLK. So this is what is done. You don't put the dye on top of the flap, you put it below the flap, that means in the interface that is there, and you can clearly see a demarcation line which is coming here because you don't want to cross-link the flap. It is not going to contribute in any way whatsoever. This was introduced by Avedro first of all, and this is the cross-linking which is called as LASIK Xtra. So this is how they actually described. So this is as you go ahead, LASIK flap that has been created. This is a femto that is creating a LASIK flap. Once you have created a LASIK flap, you take the Vibex, that is what they say, and you put it for 60 seconds. You can see that because it is under the flap, it does a good penetration, and because it is in saline, again the penetration is very fast. Because you are not using dextran, you excess Vibex is rinsed off, as you can see here. Once it is rinsed off, you put back the flap, and once the flap is repositioned, you go ahead and you give the dose that you want, which is the ultraviolet light, which is supposed to be given, and that is given on a high voltage, and then you see that this is given for about 60 to 90 seconds, 75 seconds in this case, depends if you are using 45 or 30. I'll tell you what we use. So this is, you can see the demarcation line that comes, and the total amount of energy that you use is 2.7 joules, and what we use is a 30 megawatt milliwatt, and what we do is for 90 seconds. So this is what the standard protocol that we use for doing a extra procedure that we have, whether it is a extra procedure for PRK, LASIK, or for a smile procedure. And as I told you, we don't do it through the flap because you don't want to cross-link the flap. It doesn't help because it's already a separate and it can cause flap shrinkage. What has been shown by a couple of studies is that the outcomes in number of patients, 90% went on to come within 0.5 diopters, and it has been shown that it does not cause progressive steepening because it's a suboptimal dose. If it's only a full dose of cross-linking that is given, that you will get flattening, otherwise you don't. Just a case example where you can see these are borderline where you have the bad score, etc. And safety and efficacy have been compared by several authors. So you can see a lot of authors who are giving you great outcomes for LASIK. And then you come on to Smile Xtra. In Smile Xtra, you just do the normal smile procedure. You will see this is the normal smile procedure that is being done. Lenticule being created, lenticule being taken out. Once the lenticule is out, then you again take 0.25% of Vibex. You can see here, this is going ahead, just putting a little bit of the local anesthetic drops. You're putting the Vibex, let it remain for 60 seconds, wash it out as you can see, and then go ahead and do the cross-linking in this particular case. These are again studies which can show that long-term treatment of Smile Xtra in myopia gives great results. Shri Ganesh's study, you can see this is a case, again, borderline. One could go ahead and do the cross-linking. Obviously, it's going to take a lot of patients to actually see whether there's a statistical difference or not. Pooja has just left, but what they have shown is the Smile Xtra works much better than a LASIK Xtra. As regards comparing of the biomechanical strength, which is tested subsequently. But a long cross-sectional study would be required to actually say whether it makes a statistical difference for that or not, since there are no adverse effects that are there, and it gives you a sense of, I would say, whether it's false or whether it's a true, but it gets you a sense of satisfaction that you have in borderline corneas. Sometimes the pentacam overestimates keratoconus or thinks that this has a possibility of going into ectasia. So you can do ahead safely, securely an extra procedure, and that will give you the additional strength to sleep better at night, and maybe the patient also has long-term benefits of not going into ectasia. Thank you very much for your kind attention. Thank you.